because of that, because of the importance, we have two wonderful speakers here today. And I'll introduce them in just a moment. First, I'd really like to thank the Oliver Center for providing videotaping. If you don't know, all of these lunch bunches are videotaped. They're available on our UTMB website for the lunch bunch, and also on the pelvic health website. And hopefully it'll be on the breast health website as well. So if you miss one or want to go back and really refresh on what's been said, turn to that videotape, and that's provided by the Oliver Center. Also really like to thank UTMB for providing a wonderful lunch, support, marketing, all the things that make the lunch bunch really possible, so we can promote good health in our community.
Okay, so I'm Dr. Robinson. So just briefly, I'll give you a brief introduction of myself, where I'm from. So I'm Texan. I am from Round Rock, which is outside of Austin. I went to Texas A&M University, Gig 'em Aggies, woo, there you go. And then after that, I went to medical school in Dallas. I did my training, my residency training at Mayo Clinic back in Dallas and in San Antonio. And all that equaled up to internship, radiology residency, and then I did a year of a dedicated fellowship in breast imaging, okay? So I am a very laid-back speaker. Some of you, somebody has mentioned that they've heard me speak before, so if you have any questions, if I'm saying something and you're like, I don't get what she's saying, you just feel free to stop me. Just raise your hand or just say, hey, Dr. Robinson, what are you talking about? And then we can just go over the questions, okay? All right, so let's go. And we're gonna have official questions at the end as well, right? But if you have a pressing question and you say, oh, I have a question about that picture, you can just go ahead and stop me and we can talk about it, okay? Now, so let's start with this. This is Breast Cancer Awareness Month, so we see lots of ads and everything that says that 1 in 8 women will be diagnosed with breast cancer sometime during their lifetime. So the question is that really true? Well, it is true, but what you have to think about is they're talking about throughout an entire lifetime. So this is a table where we're looking at age, and if you look across the bottom, this has women's ages, and it goes from 25 all the way up to 95. And what the bars represent are the number of women who are diagnosed with breast cancer. So what does this table mean to you? This means that when you're younger, although you can be diagnosed with breast cancer, it's relatively rare in a younger population. The older we get, the more likely it is that someone will be diagnosed with breast cancer. So when they say that women have a 1 in 8 chance of being diagnosed with breast cancer, they are tying in all of these ages, okay? So if you personally would have a 1 in 8 chance, that depends on your age. And this also doesn't tie in other things like your family history, your genetics, and other risk factors that can affect breast cancer. But so, who knows what is the #1 risk factor for getting breast cancer?
Heredity?
Not heredity.
No. Smoking.
Not smoking.
Diet?
Not diet. The #1. What are we all?
Female.
Oh,
Female, there you go. There you go. The #1 risk factor for getting breast cancer is being a woman. #2, it's gonna be age. So every year that we live, we have a slightly increased risk of getting breast cancer, okay? All right. Now, so the mammogram, oh yes.
Go back to the last slide.
Absolutely.
The red lines, the rusty and the red lines.
Here,
What ages? I can't.
80 and 95.
Oh, jeepers. Okay. The white.
That's
numbers are
good,
the
yeah.
bottom part to
So
see. Okay.
50, 80, 95.
Is
So-
that being diagnosed or that they have had it sometime in their lifetime?
This is diagnosed. This is diagnosed. So we're not looking at, oh, she had breast cancer when she was 20 and then and if that happened, if she had it young, then it would be on this end. Any other questions about this slide? Okay, so we're going to go over the screening mammogram guidelines because sometimes there's a bit of confusion out there. Who should be getting screening mammograms? How often should we be getting them? You hear different things. So we just wanted to kind of help set the record straight, okay? So the American College of Radiology, and that is the governing body over all of the radiologists in the United States, and the Society of Breast Imaging, they recommend that women start getting annual mammograms, and this is screening, meaning she's not having any problems. She's just going in for her routine mammogram at the age of 40. These guidelines are also endorsed by the American College of Obstetricians and Gynecologists, which is the governing body over OB-GYNs in the US, and the American Cancer Society. So all of the major organizations that deal with breast cancer research and breast cancer detection in the United States all say screening mammography should start at the age of 40 and should go every year. So what if I have somebody in my family that has breast cancer? So when should I start getting screened? This is what you need to know. If you have a first-degree relative, so everyone repeat, first-degree relative. So would a first-degree relative be your grandfather's friend's sister twice removed? No, that's not a first-degree relative, okay? So what is a first-degree relative defined as? That's either mother, sister, or daughter. Only those three, okay? Mother, sister, or daughter. So if you have someone in your family who is a first-degree relative to you who was diagnosed with breast cancer under the age of 40, you would start receiving your yearly screening mammograms earlier. So I'm going to give an example because sometimes that can be confusing. So, for example, let's say that there is a woman who is diagnosed with breast cancer at the age of 45. Her daughter would start receiving screening mammograms 10 years earlier. Okay, so her daughter would start getting screened at the age of 35. Okay, let's say the patient was 49. Her daughter would start at 39, and so on and so forth. Does that make sense to everyone? Okay, okay. So now let's say, what are the other things that we should be doing? So women who are 40 and older should have a breast examination performed by a professional, a medical professional. That could be your OB-GYN, that could be the nurse practitioner in the office, that could be your family medicine physician or someone else in that office. But you should be getting a breast examination every year. In addition, so some sources say that women should still be doing their exam every month, their breast exam. However, there was a lot of confusion. Women would say, when am I supposed to do it? Is it before my period? Is it after my period? Do I have to be in the shower? Do I need to be laying down? Is the arm up? Is the arm down? It caused so much confusion. What we are now going to is something that we call breast self-awareness. What does that mean? That means you are familiar with your body. And if something has changed in your breasts, then you would let your physician know. So ACOG is starting to back off of the guidelines that say you should be doing a breast exam and you should be doing it every month and this is the way you do it. Instead, they just want you to be very aware of your body, because who is most likely to notice a change in your body? You. Absolutely, absolutely. So if you're just aware of your breast and aware of what's normal and abnormal for you, then that is a good piece of information to start with and then to go into your primary care provider with. So what is it that I do? What am I? I am a breast imaging radiologist. And what does that mean? That is a fancy term for saying I look at pictures, okay? Am I a physician? Yes. Often people confuse, so when you go in to get your mammogram, there's someone who takes the pictures for you. Those are our wonderful technologists. Then what they're doing is they're going into a back room and they're showing the pictures to me. And they're saying, Dr. Robinson, here are the pictures. Do you want me to get any more pictures? What do you think about that? We interpret, meaning we look at your mammogram or your breast ultrasound or your breast MRI, and then we tell the doctor who ordered it, the family medicine doctor or the OB-GYN, what we think. Often we will also come out and talk to you as well. If you have a normal screening mammogram though, nothing's wrong, we don't see anything, often you just come in, get it, and go home. So you might not actually see me, but sometimes people say, is there really a doctor back there? Yes, we're there. We're sitting in a room in the back. And if anyone ever wants this, sometimes people have heard me speak and come and say, well, I want to talk to Dr. Robinson. I'll come out and chit chat with you, okay? So you can always ask to see the radiologist, but just know that there is a physician there. So when we give you this form and say, please fill out your history, don't just write big X's on it and say, I filled this out 3 years ago, but I'm in the back and I'm reading what you write, okay? Something could have changed.
Is that only here that a doctor is there?
Well, at the University of Texas Medical Branch, yes, we have a doctor present. I can tell you that.
So why do they send you home and say, well, we'll let you know in 2 weeks?
That's a good point. So the question is, and I'll just restate it in another way. So the question is, I come in for my screening mammogram. Why is it I got to go home to wait to hear something's wrong? And then if something's wrong, I get a letter and then I have to come back. Well, what happens is we have a lot of patients every day that are coming in for screening. However, at the University of Texas Medical Branch, if you walk in and you say, you know, I have today off because I am just busy and this is the day I got off, can I wait and get the results of my screening mammogram? Can you let the radiologist look at it? We will try our best to read it. Sometimes we're in a procedure or tied up, but we will go take a look, and then if you do have something wrong, we can tell you and we can try to get the additional pictures done then. Does that answer the question?
But you just said that you were there behind the screen.
We are.
For everyone.
We are, but the thing is, we're doing lots of stuff. We're looking at mammograms, we're looking at ultrasounds, we're doing breast biopsies, we're looking at MRIs. So sometimes they may say, yes, Dr. Robinson can read it, but it's gonna be 20 minutes because she's in a procedure right now. But if you're willing to wait, we're willing to take a look and let you know. Absolutely. Yes,
I go
ma'am.
to Victory Lakes all the time. And I don't know if there's a doctor back there or not, but they do.
You mean
exactly
Victory Diagnostics?
Yeah.
Okay.
Dr. Gaskell's that.
Yes, but yeah, and that's kind of a bit of confusion. But this is actually Victory Lakes. But yes, and some places do not necessarily have a radiologist present, which is why I can't comment on other places. But I can tell you that here in both of our locations, there is a radiologist that is present. Okay.
I know with MRIs,
Yes,
there's
ma'am.
different levels of quality about the MRI depending on the machine that's used. Is that also true with breast radiology?
That's a good point. So if I go somewhere else and they're using a different machine, will it read different? Most places now are all using digital, and I'll show you examples. But the majority of places in this area are now using digital mammography. So the images are a lot crisper, they're a lot cleaner. So there isn't a lot of variability. The variability, I would say, if there is any, is I would always recommend to my friends, family, even if they lived out of the state and they were going somewhere else, I would always get it read by a dedicated breast imaging radiologist. So that means a radiologist who, that's all they're doing all day. So all radiologists, we must train to read everything. So meaning I can read a head CT, I can read an abdominal ultrasound, I can read the x-ray if your kid falls out of the tree and breaks their arm. Yes, I can do that, and I do that when we're on call. However, my specialty is breast imaging radiology. What I trained a whole separate special year for is breast imaging radiology, and more importantly, that's what I do all day. So when you do something all day long, that's what you get really good at, okay?
So all mammograms are not equal. Well, mammograms might be equal, but the reading of mammograms is not equal.
As in any profession.
Right.
Correct, as in any profession. As in if you go, the joke I like to tell patients is, hey, if you're getting your brakes fixed, you go to Just Brakes. I mean, that's all they do. Now, if you ask them about the transmission, they say, well, ma'am, I don't know. This isn't what I do, but that is what they do. So yes, there are general radiologists who are very good, but who read a lot of things. And then there are dedicated breast imaging radiologists who are fellowship trained and who that is what they do all day. In addition, a breast imaging radiologist is much more likely to have a rapport with the breast surgeon. So Dr. Silva and I talk all the time. all the time. So we have a lot of back. So if I see something and then I want her opinion, we are just right across the hall from each other. So I say, hey, what do you think about this? This is what I'm thinking. What do you think surgically would happen? And then she can come back and say, hey, you know, I'm seeing this and this is what it feels like. Can we take a picture and you look and you tell me what's going on? So in addition, you're going to get that multidisciplinary approach, which is very important. Okay, so mammogram. So I like to show a picture because I know how many ladies love getting mammograms. Show of hands. One, okay. So I like to show this picture. I know there's no takers in the room. Just so you know, this is how we obtain the mammogram. And no, we are not torturing you. And why do you do this? And why do you do the pressure? This is why, and we do very gentle pressure. We have wonderful technologists here who've been doing this for many, many years. And I've had many patients come and say, you know, that really wasn't bad. But I'm gonna let you know why we do what we do. This is why. So these are 4 different women. And what this slide is showing is that different women have different amounts of density in their breasts. So what does that mean? That means it can be hard for us to see on some women. So if you're this woman, it's easy to see through your breast. However, if you're this woman, this is a breast that we call extremely dense. This has a lot of white tissue in it. So as a result, sometimes it can be a bit harder for us to look at this image. So when the technologist is saying, oh, I need a reposition, or when they go out of the room and come back and say, oh, I have to take another picture, we're doing that because we want to make sure we are getting all of the information that we need to give you an accurate diagnosis, okay? So, screening versus diagnostic. Sometimes you will come in and you aren't having any problems and you just can walk in, get your mammogram and go home. There are standard views that we do. But let's say that you're having a problem. You feel something, or you're having discharge, or your physician felt something. That's a different type of exam. That is called a diagnostic exam. For those, typically, we're going to need an order from your physician, which we are more than happy to call and get the order, but we're gonna do additional studies. We're gonna do, this is a spot compression view. You can tell there's this paddle that lets us press in on the tissue and look, and if you notice, you can see a mass there. This is a breast ultrasound, and this is a magnified view. These are calcifications in the breast. And again, it's not necessarily important to know which of the views we're going to do because we make that decision when you come, but just know that if you're having a problem, or if you write down on that sheet that I'm having a problem this year, that's no longer a screening mammogram. That's a diagnostic exam where we're gonna have to do additional images. Does everybody understand that? Yes, ma'am.
Is there a difference in price between a screening and a diagnostic? I know, like with colon.
Like colonoscopy?
Colonoscopy, that's
Uh-huh.
what I'm, a screening colonoscopy is usually covered by insurance.
Correct.
Whereas a diagnostic colonoscopy isn't. Is that true here?
Okay, and I'm glad that you brought that up. It's not that a diagnostic is not covered, but you may have to come out of money, out of pocket.
That's what
Yes,
it is.
depending on what your insurance is. So the screening is just the general preventive. You know, just like, you know, with most insurances, most dental insurance covers, you can get the cleaning every year. However, if you have something, then you may have to pay a little bit out of pocket. And depending on your insurance, some has very little to nothing that you have to pay out of pocket. Some may have a little bit more of a substantial price, but yes, it is different. So if you mark on there, oh, I'm having a breast problem, and then we come and tell you, okay, you're having this, so now you're gonna have to pay a copay, and you say, oh, never mind. I don't feel anything in my breast, never mind. Never mind, I don't, the thing is, you've already, you know, you've written that, and we put that in our medical records, and we really want to do the best thing for you. This is not, we're not doing this just to do an extra exam. We really want to do the best thing for you, and that's why we do this.
Question when you press, but then these days, a lot of women has a breast implant.
Yes.
How they can detect that?
We
It's just
do. We
curiosity.
have. I'm glad you brought that up. I am asked about breast implants more than I'm asked about breast cancer.
Oh.
So a quick side. That's true. So a quick side note about breast implants. So if you have breast implants or know someone who has breast implants, first of all, they're very common. Very, very common.
Yes.
What we can do is we can do what we call implant displaced views. We can very gently slide the implant over, And then, oh, you have a look on your face. We can slide the implant over and we can take pictures that way. Mammograms do not, there's no contraindication for getting a mammogram if you have implants. So we take the regular views plus we take a few additional views.
Also,
Yes, ma'am.
is there any chances that they can get also cancers? It doesn't matter implant or not implant?
Implants do not increase your risk of cancer, but can someone with implants get breast cancer? Absolutely. Just like the general population, though.
Thank you.
So a few things that can be found on an abnormal mammogram. We could see abnormal calcifications. We can see a breast mass. Here you see the outline of a mass. This is actually a very common benign mass, so not cancer. So every time there's a mass, it doesn't mean that it's going to be something worrisome. Breast implant irregularities that we talked about. We can also see irregular lymph nodes, and that's something that Dr. Silva is going to talk more about. But these are all things that we can see just from your screening mammogram. Now, what about the other tests that we do? Breast imaging radiologists, we also perform breast ultrasound. So typically what happens is our technologists will go in, perform the ultrasound. They come show us the images, and then we often come behind them, perform the ultrasound ourselves, and look. So what we're doing with that is we're getting a little bit more of a deeper look of the tissue. So this is an example of a breast mass that is seen on a breast ultrasound. And again, just because we see a mass, it doesn't mean, so if we say we see something, that doesn't necessarily mean it's something worrisome. It just means that there's something, and then we need to do a little bit more additional investigation. So now addressing what you asked about breast MRIs. So typically a breast MRI, there's only a few guidelines for why women are getting breast MRIs. These are women who are in a high-risk population, which Dr. Silva will also address if they are BRCA1 or if they have a over 20% lifetime risk of getting breast cancer. They get breast MRIs. Women who are diagnosed with breast cancer and have those dense breasts that we saw earlier, sometimes we need to do a breast MRI because we need to look in the other breast to make sure that there's not something worrisome. We also can get breast MRIs if some patients can have something, what they say, an unknown primary tumor, meaning they did an axillary lymph node biopsy or a biopsy somewhere else in the body, and it says, we think it's a breast tumor, but we're not seeing anything on the mammogram. Then we can do an MRI to do further evaluation. Also, implants. If there's an implant irregularity, we often will do an MRI in those situations as well. So this is just an example of how we do the MRI. We have an MRI machine that is specialized, that we have a special coil to address what you said earlier. We have a special coil that's used for breast. So we use it on the breast coil here and in Galveston. And if we see something, like for example, this is a mass, this is the heart, just to give you all reference point. This is the back of the patient, this is the front of the patient. So if there is a mass or some abnormality that we see, we also have biopsy capabilities where we can do a biopsy from the MRI in both of our locations. So what if you end up needing a procedure? What do we do? So briefly what we do, this is an example of an ultrasound guided biopsy. So this is going off of a patient who came in, we saw something abnormal in the breast and say we need to do a biopsy. If you go 15 to 20 years back, this was something that went to the operating room for them to tell you what it is. Now we can do this in the office. The biopsy takes about 20 minutes. What we do is we get the ultrasound probe, we give you numbing medication, and we have a biopsy device that lets us take small little pieces of tissue. This is a needle. It comes out in something the size of a needle. We get those pieces, and then the pathologist can tell us the results. What if you have calcifications in your breast? If you have calcifications, we have to do something that's called a stereotactic biopsy. Very fancy words for, you're gonna lay on the table on your belly. There's gonna be an opening in the table. Your breast is going to be in that opening in the table. Again, we'll give you numbing medication, and we have a small needle that lets us get out little pieces of tissue. We take out the calcifications, we send it to the doctors that look under the microscope, and then they tell us the results. It's a lot of fun. Well, okay, but if you compare that to being put to sleep,
Sleep and excision.
and get it and an excision, exactly, and it's going in with something the size of a needle. So I wouldn't call it a walk in the park. However, we definitely have patients who get this done and go back to work the same day.
Very cool.
Yes, yes, ma'am.
I had one of those about a year ago, and they
Yes,
put a
ma'am.
marker in.
Absolutely. Okay, so I can go a little bit, yes, into the marker. So we have very teeny tiny, it's the size of the tip of a writing pen, titanium markers that after we do a biopsy, we place a marker in the breast. We do this for 2 reasons. So reason number 1, let's say that you win the lottery and you move to Hawaii, okay? And you're starting to get mammograms now. You're in Honolulu getting your mammograms. Well, what's gonna happen is when they get your mammogram, they're gonna look and say, wait a minute, what is this in her breast? But if they see that clip that I placed and know that, and they will know by default, it must not have been anything worrisome. So it limits confusion in the future for when patients move. So let's go to scenario 2. So scenario 2 is going to be that it's something that we say, you know, this needs to come out of your breast. So when my colleague, when Dr. Silva takes it out, she calls me from the operating room. They come up, they take a picture, and then I look for that clip that I placed. And then she calls me or I call her and I say, hey, you got it. I see my clip. So it's just a second way to verify that we are in the area that we took the biopsy for. It does not go off in airports. It does not track you. These are all questions I've been asked. It doesn't track you. It doesn't go off in airports. Yes, it's not a chip. It's, you know, it's simply a small marker that just lets us know what was done. And again, it's helpful for you if you move and go somewhere else. It's MRI compatible, absolutely. There's no radiology test that you cannot get with those little clips. And for the people that say, well, I don't know if I want a clip, I mean, we very much discourage against that. Because again, what if 5 years from now, there's something else in your breast? The question's gonna be, well, is this what they biopsied or is this something new? And it's always gonna be a question. If there's a clip, it eliminates any question in the future. Okay? Yes, ma'am.
If you can't have an MRI, what happens to that step? Do you go immediately into surgery?
No, ma'am. We actually also have additional tests that can be ordered. Here we have something called breast-specific gamma imaging. So what that is that they can give you something in an IV, and when they give you, it's what we call a radio tracer. When it goes in, it goes through your veins, and it eats up little cancer cells. And so when it eats up those cells, then it gets bright on a picture. So we can take a picture that way. There are also additional tests. Sometimes we can do a different type of ultrasound to go back and look. So if someone cannot have an MRI, possibly they have a pacemaker that won't allow it, possibly they're claustrophobic. There are a few reasons sometimes that patients cannot get MRIs. Often we can still work around that. Okay?
Okay, so I'm Colleen Silva, and I'm a breast surgeon. I'm also a Texan. I grew up in Beaumont, so on the other side of the ferry from here, but I went to medical school at UTMB a long time ago. I'm now at that age where my medical students were not born when I was in medical school, so that's really depressing. But we're going to talk a little bit now about what we're going to do once Dr. Robinson identifies that we have a breast cancer. What do we do now? And so it's really confusing in a good way, because on the one hand, women have lots of options. There are lots of ways we can treat breast cancer with surgery these days. So the woman's role is very important because she kind of helps us decide what's going to be best for her and helps us make some of these decisions. But just in general, the options these days are something we call a partial mastectomy, but if you're talking to your friends about it, you probably call it a lumpectomy. The other way, we still, in some cases, have to do a mastectomy. And that means we remove all of the breast tissue underneath the skin. We take the nipple off with the breast tissue, but we still have your skin there. We use your skin to get it closed back together, and then if you're going to get breast reconstruction by the plastic surgeon, they have something to work with to do the reconstruction. In some cases these days, we can actually even spare the nipple. So we remove the breast tissue, we keep your skin, and we keep your nipple, and now you're ready for the breast reconstruction. Sometimes we do breast reconstruction on the very same day you get your mastectomy, and sometimes for various reasons we do it down the road after you've finished your chemo or your other treatment. Or sometimes women think that at the time that they're dealing with their cancer, this is too much for me to cope with, I can't think about this right now, and they decide not to do the reconstruction. But 3 years from now, they feel back to normal, they're living their normal life, and they decide at that point to do reconstruction. So it's possible to do reconstruction early on, immediately, or do it down the road. So how do we decide? How do I help guide women? Do you need the lumpectomy, or should you really be thinking about having a mastectomy? Well, part of it has to actually do with size. If we're dealing with a really small tumor, something about the size of a pea, and someone who has a very large breast, and I take out that piece, you probably never even notice that it's gone. But if we're dealing with a tumor that's the size of an orange, and a woman has an A-cup breast, if I take that out, that's going to be a big change in the way their breast looks when I take that lump out. So that's one of the things that helps us decide. Is there one tumor in this woman's breast, or in some cases, and not that commonly, but it does happen, women can have 2 cancers at the same time. So if I take out 2 big pieces from the breast, how is that breast going to look after the surgery's over? Again, what does the patient want in this whole process? And if you choose the route of going the lumpectomy route, we're pretty much going to tell you after the surgery's over and you've recovered, you're going to need radiation. So you have to be willing to buy into that it's a team approach. You're going to get the lumpectomy, but you're also agreeing that you're going to do the radiation therapy. So again, just to kind of reiterate it in slightly different ways, there's only one tumor that we kind of know about. We can get it out. We think we get it out completely, and what we have called negative margins, meaning when the pathologist looks at that piece of tissue that I've given them, that lumpectomy, and they look at it under a microscope, what we want to know is that the cancer is kind of sitting right in the middle of that piece, and all the way around it's encased by normal looking tissue. Because that's our guarantee as much as possible that we're not leaving cancer still behind in the breast. The bottom line is the goals are twofold. We want to do a cancer operation. We want to get the cancer out and be pretty confident that we got all the known cancer out. But we also want to end up with the breast that the woman is happy about. That when she looks in the mirror, she's okay with the way that her breast looks now that we've taken out a piece of it. Same on the other side. Why do we sometimes still tell women they need a mastectomy? Why can't everybody get a lumpectomy? One, there's more than one cancer in the breast. We're worried that when we do this lumpectomy, the tumor is so large that there's a chance we're going to be leaving some of the cancer cells behind. We're not going to be able to get those clear or negative margins. The patient either can't find a way to get here every day to do the radiation therapy, doesn't want to do radiation therapy, is afraid they can't lay on the table that they need to lay on to get the actual radiation therapy. So if you know from the beginning, there's no way I'm going to commit to radiation therapy, and we probably should be thinking in the direction of doing a mastectomy. And then people who are the BRCA1 and 2 genetic carriers, we try to steer those women to mastectomy as well. That doesn't mean that every woman out there who is a BRCA carrier makes that decision, but if you ask our professional opinion, if you are a breast cancer genetic carrier, should you have a mastectomy, we would say yes. So what are the breast cancer genes? All of us are made up of genes, DNA, and every day some of our cells are dividing. And when those cells divide, meaning one cell becomes 2 cells, there's always a risk that a mistake happens in that process, that the second cell has an error in it, or it's been altered in some way, it was damaged in some way when it divided. We all carry BRCA1 and BRCA2, but what we want are the normal BRCA1s and BRCA2s. So that means that those genes in our body, they make a protein that tries to go into cells that have been damaged and fix those cells. Because if those damaged cells then go into divide into other damaged cells, they can become more and more altered, and ultimately those damages lead to the growth of a cancer. So those genes, the normal version of those genes, we call them tumor suppressor genes. Their job is to fix the abnormal cells that have gotten broken in a way when they divided and try to repair them. If you don't have a functioning BRCA1 or BRCA2 gene, then you don't have the ability to repair those cells that are abnormal. So it's not that you have the BRCA1 or BRCA2 gene, it's that you have a version of it that's not working. It's not doing its job. Now the good news is that of all the women who get breast cancer, only 5 to 10% of those women are carrying the BRCA gene. Unfortunately, the vast majority of women who get breast cancer, it was a random event as far as we know at this time. So if you are a BRCA carrier, then you remember that graph that Dr. Robinson showed at the beginning where it keeps going up and up and up as you get older, so that ultimately you've got that 1 in 8 chance that you may get breast cancer by the time you're 95, or put it another way, you've got a 10 to 12% chance that you're going to get breast cancer by the time you're 95. And the BRCA carriers, that number is that the 45 to 65% of those women, so 50 to 60 women out of every 100 that is a BRCA carrier will have breast cancer by the time they're 70, whereas in the normal population, it's like 1 out of 10 women in that time period. Interestingly enough, and we don't think about this enough, but men can carry the BRCA gene too. Men do get breast cancer, but in the normal population, it's about 0.1%. So it's a very rare occurrence for a man to get breast cancer. But if they carry the BRCA abnormality in their family, they have about a 7% chance that they're going to get breast cancer by the time they're 70. And the other problem with the BRCA genes is that it increases your chances not only that you will get breast cancer, but it increases your chances you will get ovarian cancers, fallopian tube cancers, in men, prostate cancer, and then both in men and women, pancreatic cancer. So I want to talk a little bit about mastectomies and bilateral mastectomies, because we see a lot in the news media. Some reporter gets breast cancer and the next week she chooses to have both of her breasts removed. And I want to talk a little bit about that, because unless you're a BRCA carrier, most of those decisions to have both your breasts removed are being made by the woman and are mostly fear-based and not related to the actual facts. So I want to kind of get the facts out there. If you get breast cancer in one breast, the chance that you are sometime down the road going to get breast cancer in the other breast is it's about 3 to 10%. So let's say that you're 70 and you get breast cancer. By the time you're 80, you have about a 3 to 10% chance that you may get breast cancer. I think what happens is women believe that it's a done deal. I got breast cancer, I'm destined to get it in the other breast. And they make that decision to have both breasts removed, when really it's 3 chances out of 100 that you're going to get breast cancer on the other breast. Now, if you got breast cancer and you were young, you were before menopause, and one of your first-degree relatives, so your mother or your sister or your own daughter got breast cancer as well, then the chance that you'll get breast cancer in the other breast is a little bit higher, but not that much higher. So 15% chance. Now these are all women that are not known to be BRCA carriers. We're not talking about BRCA carriers here. We're just talking about the vast majority of women who get breast cancer. So we keep working, so I'm sorry, go ahead.
Can I ask one question?
Sure.
How do you know if you are BRCA carrier?
So that's a very good question. So people who are BRCA carriers, they tend to fit a profile. They are either very young when they got their breast cancer. So in Dr. Robinson's graph, way down here on the young ages when very few women are getting breast cancer, those are the group of women that are likely to be BRCA carriers because they were very young. Huh?
Would you know that you're a BRCA carrier?
Well, the other part is your family's history. So when we map out a family tree for a woman who is a BRCA carrier, what we see is that she's not the only woman in the family who had breast cancer. In fact, there's probably 2 or 3 or 4 other women who had breast cancer, or maybe there was a combination of some women had breast cancer and some women had ovarian cancer, or her father had pancreatic cancer. So we see a family tree that makes us suspicious. So that's the people that we decide to test. They have a suspicious family background, so family tree of young people getting breast cancers, multiple people getting breast cancers in both breasts, ovarian cancers, and that's who we decide to test. So we don't test everybody because we know that of 100 women who get breast cancer, 5 maybe of those women have the BRCA gene. 95 of them don't. So we do it based on looking at the patterns. Mm-hmm. So the other part of treating breast cancer are the lymph nodes, that we have to take care of knowing what's going on in the lymph nodes. Because unfortunately, just examining you and feeling whether or not you have a big lymph node underneath your arm, or whether or not Dr. Robinson sees some abnormal lymph nodes on her mammograms or ultrasounds or even the MRIs, is not a 100% guarantee. The only way to know absolutely certainly whether or not there has been cancer that has gone to the lymph node is to get a biopsy. And sometimes Dr. Robinson does that biopsy. She does it with a needle, okay, and takes a little piece out of that lymph node, just like she took a little piece out of the breast. And sometimes we actually take out some of the lymph nodes in the operating room. But the other key thing to remember is some women believe that if it's in their lymph nodes, now they have to have a mastectomy. That is not the case. Think of the lymph node surgery and the breast surgery as 2 separate things. So you can have cancer that has spread to the lymph nodes under your arm and still be able to keep your breast, still be able to have a lumpectomy. Okay. So what are the lymph nodes? Well, right now, all of us have circulating through our body. We have blood, it's circulating through our body. But we also have lymph that is circulating through our body. So it's like we have 2 types of circulation going on: blood circulation and lymphatic circulation. So this lymphatic network, these little vessels with lymph fluid flowing through them or traveling throughout your body, and their job is to filter out things that your body's trying to get rid of. Cells that don't work anymore, bacteria that have gotten into your body causing an infection. So they're trying to filter out all these things that you don't need or you don't need to have in there. So every so often along these plexus of lymphatic channels, there are these nodes. And think of them like a filter. Their job is to filter out these things and get rid of them. Because in these lymph nodes, there are cells that their job is to destroy whatever that lymph node traps. Unfortunately, they're very good at destroying bacteria, but not so good at destroying cancer cells. So cancer cells can get trapped in there and then start to grow in the lymph nodes, and from there ultimately get to spread into the bloodstream to go to other parts of the body. So it's important to know, has the cancer gone into the lymph nodes yet? Because we know once that happens, then that chance exists, that possibility exists that cancer is going to show up somewhere else, far away in the body in the future. Okay. So if you're diagnosed with breast cancer and your breast cancer is called invasive, meaning it has spread outside of the milk ducts. So most breast cancers, and we don't know why this is exactly the case, but the vast majority of breast cancers actually start in the cells that line the milk ducts. While it's still just trapped inside the milk ducts, we say that's non-invasive breast cancer or stage 0 breast cancer. So if you have stage 0 breast cancer, we will probably not check any of your lymph nodes because we know the cancer hasn't had the ability to get into the lymph channels. But once it goes outside the milk ducts and it's in the fatty tissue that surrounds the milk ducts, that's where the lymph channels are running. So that's how the cancer cell moves from that spot in the breast through the lymph fluid to a lymph node. If you come to us and by Dr. Robinson, your mammogram, your ultrasound, your MRI, and when I examine you, I don't feel any abnormal lymph nodes, and we're going to still check a few of those lymph nodes, then those are called the sentinel lymph nodes, meaning we just take out a few lymph nodes from underneath your arm, 1, 2, or 3, a couple, okay? We take out the lymph nodes that would be the first ones in the lymph node chain. So if you could, and it's not possible to do it, but if we could, take all the lymph nodes that you have in the fatty tissue underneath your arm and spread them out, it would be like a string of pearls. And the cancer is not going to randomly just go to any pearl in that chain. It's going to go to the first one and then the second one and work its way up. So we have the ability, we have the technology to be able to identify what is your number 1 or number 2 or number 3 lymph node. And we check those. And if those don't show cancer in them, we don't take out the rest of your lymph nodes. Now, if Dr. Robinson sees an abnormal lymph node when she does your biopsy and she biopsies it and it proves that you have cancer, or when I see you and you have a bunch of big, really abnormal lymph nodes that we're pretty confident have cancer in them, then that's a different scenario. In that case, you get what's called an axillary lymph node dissection, meaning we're going to take out most or all of the lymph nodes that are underneath your arm, not just a couple to sample. Okay. The problem with taking out all the lymph nodes underneath the arm is that we increase the chance that you'll end up with something we call lymphedema, which can be permanent swelling of the arm and hand region. And we don't like that to happen. So why do people get lymphedema? Well, you've got this lymphatic channels, right? They're running through your body. That lymph fluid is flowing through there all the time. And now we've put up a roadblock because we took out all those filters that were there. And now there's scar tissue there. So that lymph fluid that normally would be circulating through your arm and back out, it gets trapped. It gets roadblocked here because we've taken out those lymph nodes. And so it gets backed up. It's like a blockage. So you get swelling in your arm. You can get lymphedema for reasons other than having had breast cancer. There are other reasons people get lymphedema. Anything that's going to disrupt or interrupt or block that flow of the fluid. So maybe it's from cancer, maybe it was from an infection, surgery for some other reason, scar tissue, getting radiation to an area. All those can lead to lymphedema. And the problem with lymphedema is sometimes it occurs very quickly after we do the surgery, but we have women who've had their breast cancer surgery 10 or 15 years ago who get lymphedema. So we can't predict who it's going to happen to, and secondly, we don't always know when it's going to happen. Few days, few months, sometimes years later. So what percentage of the time does that happen? Well, if we have to clean out all the lymph nodes underneath your arm, then there's about a 16% chance that you're going to get swelling. It may be more. That means for every 100 women that we take out all the lymph nodes underneath their arm, 16 about of those women are going to end up with some degree of swelling in their arm. Now sometimes it's subtle. It's like a ring that used to fit or a bracelet that used to fit doesn't fit anymore. But sometimes it's dramatic, where one arm can be double the size of the other arm. And we don't like that to happen. It means if you try to wear a long sleeve blouse, it's possible your arm won't fit into that blouse. The arm may feel heavy. It may be difficult for you to use. So we want to avoid that whenever we possibly can. And that's why we went to, once we developed the technology, we went to the sentinel lymph node surgery alone just as a sampling procedure. Because when we do that, the number of women who get lymphedema is about 5 women out of 100 instead of 16 or 20 women out of 100. And that pretty much wraps up what I was going to say. And now I'm open to any more questions that people would like to ask. And thank you. I'm sure Dr. Robinson will answer some more too if you guys thought of something else. And you?
I'm interested in, I think it's inflammatory breast cancer. And how's that usually, talk a little bit about that.
Okay. So inflammatory breast cancer is based on the appearance of the breast when we see the woman. So if you come in and your breast is red, it's hard, it's bigger, like dramatically bigger than the other breasts. I mean, we're talking about something that even if you weren't a breast surgeon and you looked in the mirror and looked at this woman's breast, you would know that there is something wrong. There is a problem, okay? So sometimes I have women who come and they're very scared because, for instance, they've had some itching on their nipple and they've been told that that can be a sign of inflammatory breast cancer. Most times it is not. Most times it's just dry skin or something along that line. So it's not subtle. If you have inflammatory breast cancer, this isn't something that you're scratching your head, do I have no, this is, you look in the mirror and there is obviously something really wrong with this breast. Because what happens with inflammatory breast cancer is remember when I talked about mastectomies, I said we take out the breast tissue, but we leave the skin? Because the vast majority of the time, the skin is not part of the cancer problem, but in inflammatory breast cancer, it is. The cancer cells are actually in the lymphatics of the skin, and so that's why their breast looks like that.
So why do they wait so long, and if it's so obvious, what, that they die from?
You know, I
Often, and some people think it's infection. There have been, there are quite a few people who see changes and it can look red, like she said.
Yeah.
So sometimes it looks like, if, you know, when women breastfeed and sometimes
You
the
get
breastfeeding
mastitis.
infected, mastitis, sometimes people just thought it was infection.
Okay.
So that is probably the number one thing I've seen just in clinical practice. They thought it was infected.
like they've had an infection before, and it
Right.
seemed like that.
And they were rubbing cream on it and doing, you know what I'm saying? They were going through all of these things.
Yeah, I got a girlfriend that was diagnosed late. The CP was treating as an abscess, and it took about 3 months before it was too late.
Well, and that's a good point. I'm glad you said that. So 3 months. Sometimes people will say, "Oh, well, you know, what about? I was there 3 months ago, and is this going to change anything?" And we brought it back. All of the literature points to no. No. So if there is something, we do something that if things look probably benign, we say that we're going to bring you back in 6 months and we're going to take another look. But if it's changed in the 6 month time, then we're going to do a biopsy. And those are people that we feel 98% certain it's benign. But what if they come back and it's, oh my goodness, it's different, and we do a biopsy and it does show a cancer? The reason that we say that 6 month time frame is that all of the literature has shown that that does not change the patient's survival. So, and you got to remember, cancer is a process that was slowly growing. It takes a while before it even gets big enough so that we can see it with our human eyes. So it's not that you just developed cancer yesterday. It's that it got to a size where we could detect it on a
You
study.
may have had those cancer cells in there for 2 years, we don't know, before they ever get to the point where we can actually detect them, even on the best mammogram machine in the world.
Right.
You know, it has to get to a certain size before we can
I
see
have
them.
now than those around us, so thank you, ladies.